speak for all of us, I believe, in thanking Governor Mike Beebe for being our featured guest today. Since taking office in 2007, Governor Beebe has focused on improving Arkansas's educational system, expanding its economy, and with his wife, Ginger, championing the elimination of childhood hunger. In the context of today's breakfast, Governor Beebe has championed the first in the nation private option plan to win federal approval as an alternative to expanding the traditional Medicaid program. While the governor's plan in Arkansas has its skeptics among Republicans, not all Republicans in Arkansas, it is serving as a model that other states are considering. Only yesterday, Tennessee's Republican governor, Bill Haslam, was scheduled to meet with the Health and Human Services Secretary Sebelius in an effort to hammer out a flexible arrangement similar to that of Arkansas. With states assuming new roles by virtue of the Affordable Care Act and the Supreme Court's decision declaring it constitutional, the United States is entering a new era of federalism, with states assuming a larger place in shaping public policy. Governor Beebe does not have an opening statement, but he will entertain our questions. Now I will turn it over to our moderator this morning, Mary Agnes Carey of the Kaiser Health News, and who will pose the first question. Mary Agnes, please.
Thank you. Thanks so much for that introduction. I will open it up. I know everybody here is eager to ask questions, but I just wanted to talk a little bit about the week you had and the week you're going to have. The Senate did approve continued funding for the private option, but the House did not. On 4 different votes, you were just a handful short. Sometimes it was 3, sometimes it was 5 votes. You have another vote set for Tuesday. What's your strategy? How are you trying to get those votes, and what happens if you don't?
Well, I think everybody needs to understand, first of all, the hurdle that has to be overcome in sheer numbers, 75%. That's really the story. I mean, the Washington Post, the New York Times, the Public Broadcasting Service, all sorts of different folks, AP, have inquired about all this, and in many instances they say, how come there's so much opposition? There's not so much opposition. 75% vote is required. 75% has already been obtained in the Senate, 27 to 8. That's not much opposition. In the House, we think the vote as it stands today is 73-25 with 2 undecided. If you get those 2, you get 75. So I think people need to understand that because of peculiar quirk in the Constitution, appropriation bills, which is really what this is just the authority to spend the money. The approval for the program required 51%. If we were talking about 51%, we wouldn't even be talking. If it doesn't pass, there's a very small minority of people who will have stopped it. What's the strategy? The strategy is telling the truth. What we did last time was we determined through various means that by utilizing the private option, which was the ability to take public Medicaid money and buy private insurance with it for exactly the same population, requiring exactly the same, at least minimum requirements that Medicaid expansion would have required, that we were able to save roughly, excuse me, $86, $88, $89 million in general revenue that otherwise would have been spent had we not accepted Medicaid expansion in the form of a private option. The legislature wanted to and decided to give that money back to the taxpayers. So they passed, and I supported tax decreases comparable to the amount of savings generated by the private option. They're not going to repeal the tax decreases. I mean, politically, that's not going to happen. So the ramifications of not continuing the private option would be that you'd have an $86 million hole in the budget. What's the strategy? Tell them the truth. What's going to happen to the budget? In Arkansas, K through 12 is sacrosanct. So you're not going to touch K through 12 funding. That's roughly 50% of the general revenue budget, which means 100% of those cuts to make up that $89 million will come from just 50% of the budget. The ramifications are significant. I'm sure there'll be, if there's 135 legislators, there may be 135 different approaches to how you would make up through cuts in the budget that loss of that $86, $88 million in revenue. And once they look at that, it seems to me, the choices are going to be very difficult. We just keep telling them the advantages. There's no difference this year in terms of any negative reason why they would vote against it. In fact, there's more positive reasons this year than there were last year. We got the questions answered. Now, last year when we passed it, we were still unsure as to whether the federal government was going to grant the waivers, the specific waivers. A lot of what was done was contingent upon the federal government granting that. That's happened. So the uncertainty that existed at the time it was originally approved by 75%, all those questions have been answered positively. And as I indicated, we've passed tax savings on to the voters subsequent to that. So that's another reason. And now you've got 100,000 or more people that are on health insurance that didn't have it before that would now be taken off of health insurance. So all of the objective factors, it seems to me, that would indicate that a positive vote, a continuation would be warranted in order, are there, and then some, over and above what it was last time. So the good news is that the Speaker is willing to keep voting. You know, at some point, I guess you have to figure out if you're not going to get that last one vote or that last two votes, you have to figure, okay, here, let's throw out another budget. Let's start talking about budget cuts in areas. We've got some other significant budgetary problems, and my proposed budget addresses those. But it goes away. The proposed budget goes away. So that's where we are.
All right. Well, let's open it up to the audience. Reporters, I'd like you to please state your name once you get the microphone, your outlet, and your question for the governor. Who would like to ask a question?
Got one right here in front.
Right here in front. All right. Hold on. Why don't you get the mic and restate that, Phil?
Hi, Governor. Phil Galowitz with Kaiser Health News. Nice to see you again.
Good to see you.
How much do you think, if this doesn't go through, if it doesn't continue in Arkansas, how much do you think this will affect other states that are looking at this? Do you think this will sort of put the brakes on it in other states that are considering this?
It depends on whether or not, it seems to me it depends on whether or not they analyze why it wouldn't go forward. If it doesn't go forward, it won't be because an overwhelming majority of the Republicans and Democrats don't think it should go forward, as I've already indicated. In the Senate, we've got 23 Republicans, 12 Democrats. And yet they voted 27-8 in favor of this. That's total bipartisan support. In the House, we've got 51 Republicans, 49 Democrats, actually technically 48 Democrats and a Green Party, but the Green Party caucuses with the Democrats. So I counted as a 51-48, and it's 73 to whatever, depending on where those two end up. So again, it's a majority of, it's a bipartisan overwhelming majority. If other states recognize that if it doesn't go forward, it's because a small minority stopped it, I don't think it'll have a negative effect on what other states want to do. The substance of what's going on is going to be appealing, is not going to be changed whether this passes or whether it doesn't pass. And probably there are very few states and very few governors and very few legislatures that are facing this kind of enormous hurdle. You know, I joke all the time that 75% is hard to get from motherhood and apple pie, much less something that can be controversial. You know, so I think other states are pursuing it and following along. You know, there are a lot of things happening in other states that are, how should I put this, that are interesting. One of the cornerstones by which what the federal government did to help pay for this, and incidentally, one of our arguments has been all along, we're going to pay for it whether we take it or not. everybody's going to pay for it, whether you take it or not. But one aspect of how you pay for the federal health care and the proposed Medicaid expansion, as well as other aspects of the Health Care Act, is that Medicare reimbursements to hospitals have been reduced. Those reductions in Medicare reimbursements to hospitals are going to occur with or without Medicaid expansion. And so what happens is those hospitals take the hit without any corresponding offset. And even with the offset, in most instances, they're still actually projected to lose more money than what they offset with the Medicaid expansion covering the uncompensated care. Well, the other day we had a couple of our colleagues on the other side have an epiphany, I suppose, about the potential harm to their hospitals in their states, and decried, I guess, the ramifications of the Federal Health Care Act on the reductions to the hospitals for Medicare reimbursement, as though, I mean, everybody's known this, I suppose, or should have known it for some period of time. I've been talking about it for over a year in Arkansas. And so their solution, apparently, in a couple of instances, was not to take Medicaid expansion, but to give more state tax dollars to those hospitals. It seems to me like their taxpayers then are paying twice. And that's one of our, there are a lot of arguments that we utilized. We utilized the potential penalties on small businesses that would be reduced significantly depending upon what the business was, how many of the employees qualified, et cetera. In Arkansas, it was about a $38 million estimate for small businesses that would be otherwise have a penalty imposed that would be relieved. Now that was an estimate, and it could vary, and it's hard to put a precise number on, but it's a significant number. Certainly, the effect on hospitals, just on our medical teaching hospital alone, it was $28 million a year difference to take Medicaid expansion versus not to take Medicaid expansion. So, I mean, that was an argument. I use the oversimplified analogy of the federal gas tax all the time, that, we're paying 18.5 cents a gallon or something in that area for federal gas tax that everybody in the country pays. Your states get federal highway money back. Some are donor states, some are donee states, but we all get some degree of money back from the federal government. And it'd be like paying your federal gas tax and telling the federal government, don't send us any of our money back. Our taxpayers want to help pay for the roads in California because our roads are fine. We don't need any help. I mean, all of those arguments and then some certainly, I think, obviate for the fact that it's arithmetic, as Clinton called it. It's arithmetic. It's not even math. And as a result of that, different folks for different reasons. And then, of course, you've got the basic altruistic reason. You're going to have people with health care coverage that never had health care coverage before. And I also point out, I was a chair of the hospital board for about 10 years when I had a real job in real life and making real income. And we saw what uncompensated care does to the rest of us. There's cost shifting. I mean, hospitals can't stay open if they continue to give 10, 12, 15, 18, 25% of their goods and services away free and not be compensated for it. So you shift costs on the rest of us. So those of us that are carrying health insurance or paying health insurance premiums or paying for these medical bills end up paying more to offset the losses. And then the taxpayers end up doing that to some extent too, in varying ways in varying states, as was part of our savings, because we were able to reduce the tax dollars we were sending to various providers for uncompensated care. We didn't have to do that anymore, or at least not as much, because they would now be paid through Medicaid expansion. So all those reasons and then some, probably more than we got time to talk about.
Now, Phil brought up other states, which is interesting, but I'm wondering if you have any tips for governors negotiating waivers with HHS. How difficult was it for you to do it? What advice would you give other governors?
Well, this is one thing all the governors are united on. It shouldn't be hard to negotiate a waiver with the federal government that's already been afforded somebody else. I mean, they shouldn't treat anybody any differently, any worse. If you're asking for more or something significantly different, then you might have to go through the process. When the executive committee met with the president last month, which many of you all, I think, may have even covered. One of the things we talked about was the fact that waivers need to be streamlined, particularly where they are waivers that are virtually identical to waivers that have already been afforded somebody else. So instead of starting from scratch, if Arkansas has a waiver that covers ABC and Utah wants a waiver comparable to ABC, don't start over, streamline it. And I think they're receptive to that. So I think other states will, I think it's the attitude of this administration. I know Kathleen Sebelius has been very easy to work with on this issue. I think what they will do is try to accommodate, unless it just totally violates the basic principles of what the statute calls for in terms of who's covered and under what circumstances.
Okay. Next question. Katie, do you have Julie? Did I see Julie's hand up? Julie Rodner?
There's all kinds of hands up back here.
Thank you. Julie Rovner from NPR. I know that Medicaid expansion wasn't technically on the agenda this weekend for the governors, but is this something that came up privately, informally among the governors?
And that's where it did come up. It came up privately. You know, the NGA is notorious for trying to stay away from controversy. I mean, well, you know, you're sitting there and you got Republican governors, you got Democratic governors, but there are so many issues upon which we can agree. It's usually anti-Congress stuff. But so there's enough business to do without getting into things that you have such a huge division on. But privately, I was approached, and don't ask me the names because you know, I've already told a couple of reporters that have asked this. I'm happy for you to ask them if you can figure out who they are, and I'll confirm if they confirm. But if they come to me talking privately about what we did and what they might want to do and what they're thinking about doing, then I'll honor that sidebar, if you will.
But can you just share with us generally the kinds of things the governors are talking
Yeah,
about when it
how
comes
did
to
you do
Medicaid
it?
expansion?
What are the advantages? You know, there are a couple of substantive advantages that immediately pop out. First of all, the churning issue that occurs with those folks that are close to the upper limits on the poverty level create a problem back and forth between whether you get off of Medicaid or get onto subsidized insurance. And so that issue is significantly resolved with the way we did it because they're doing the private insurance anyway, okay? So that's one issue. Secondly, and this is a big thing for some governors, we have an insurance premium tax in our state. Some states do, some states don't. But one of the big concerns by everybody is, well, we can't afford this when the feds start making us pay a share of it, notwithstanding the fact that it maxes out at 10% in 2020. We can't afford it. So that's an argument against it. Well, what we have is an insurance premium tax, so without raising any taxes at all, we've now got an influx, by the way we did it by buying private insurance, of new revenue that can be set aside to help offset the state share of the obligation going forward. That's certainly appealing to some of those folks, particularly if they already have some form of tax in that regard so they don't have to, quote, raise taxes. But then you've got the added benefit of increasing competition because what we saw was we had more insurance companies with a greater pool of folks that potentially would be involved. We had more insurance companies come into the state for competition than we had before. So it's not just cosmetic. It's truly, there's truly a substantive difference between what we did. But the basics are the same in terms of the population that gets covered, how they get covered, what they get covered by or for, and what those income guidelines are. But that's the kind of questions that I get from other governors, and virtually every one of them. I don't know anybody's got a 3/4 hurdle yet. I think they ought to give me a medal.
Maybe they will. Who knows? All right, let's go to this side of the room. Okay, right here in front. I'm sorry, beg your pardon. I'll get back to you in a minute, John. Go right ahead.
Governor Kyle Cheney of Politico.
Sorry.
Just a quick Arkansas-focused question. You know, Speaker Carter has said, you know, he's 100% certain he's going to get the private option passed again. But you don't seem to be as optimistic or willing to say you're confident it'll get done. Is there a reason you're not as hopeful?
No. It's just my style to be a little more guarded. You know, it's Speaker Carter's got a good handle on his body. He's a good man, and he's a good judge of what's going on. It's just more my style to be a little bit more guarded about what I say about stuff like that, for a lot of reasons. First of all, I don't want to antagonize anybody over there, okay? I don't want anyone to think I'm taking it for granted. I served 20 years in the Senate. I know how governors can irritate legislatures. And I can promise you as governor, I know how legislatures can irritate a governor. But those individual legislators have all sorts of different things going through their mind. Oftentimes the less said by the executive branch on a controversial issue where some of them are still making up their mind, or at least they haven't declared themselves yet, the better. And so part of that strategy and tactic to not try to throw any gasoline on a fire. So don't take my my reticence to come out and beat my chest about predicting as anything other than me trying to just hold my powder.
Terrific. Ricardo, right there in the back.
Morning. Yeah, Ricardo Alonso Zaldivar with AP. Governor, this is connected to the rest of your budget. And what happens if you can't resolve this impasse? What happens to the rest of your budget? In Virginia, they're talking about a possible government shutdown over Medicaid. Is that something that would happen in your state also?
I certainly would hope not. It depends on, I mean, there's no telling what kind of hardball somebody could play. You know, I think that kind of hardball inevitably backfires on everybody. And so I would hope we wouldn't do that. I've got Democratic colleagues in the House that are ready, or at least they talk like they like that approach. I think last year the Republicans in Congress figured out they didn't want to do that anymore. I think the voting public would be very irritated at everybody. It'd be hard to figure out who they're going to blame for a shutdown. I think the more realistic possibility is severe and draconian budget cuts in some essential services is likely to be the result if it didn't pass. But by its very nature, I think that potential harsh remedy may be one of the reasons why Speaker Carter and perhaps others have more optimism about it passing, including me. Once you see how you get, who you hurt and how you hurt them, because you have to balance that budget, then sometimes that could have an effect on somebody's vote, particularly if you just need one vote or two.
In the back, and then we'll get to you, John.
Hey, Governor. I'm Sarah Wire with the Arkansas Democrat.
I've heard of you.
I'm just wondering if you think there's anything you could have done differently last year to convince the minority now who's not in support of private option again, and maybe what suggestions you would have for other governors.
No, I don't think there's anything we could have done different. And as I indicated a minute ago, Sarah, I think to the contrary. I think all the objections before have been positively answered. You got to look at what's going on here. You've had a couple votes switch, right? A couple of those folks are running for other offices, including congressional offices, where this is an issue, where the anti-Obamacare attitude is an issue in a primary. And some of their announced opponents are opposed to the private option that don't have anything to do with understanding what the private option is. I mean, these aren't people that have been involved in the debate. They're just running for Congress that have never been in the legislature. I'm talking about the others. And so they come out against the private option really without understanding what the private option is. They're just against Obamacare. And it's caused some people to change their vote. I would argue that that's because of a political race. I mean, I don't know any other reason for that. And you know, that's just enough to tilt the spectrum. But everything that was promised, it happened. The waiver was obtained. Everything that was outlined as to what it would be ended up being that way. So, and then you've got some people that are against it, that were always against it, and they're just philosophically opposed to additional taxpayer subsidized government programs, period. So I mean, some of those folks philosophically that were against it before are still against it. You're never going to change. But look at it this way and realize this. We had 77 votes in the House before. By our last count, we got 73 now. So I mean, you had 4 people change for whatever reason, if the count's correct. And those reasons could be political. They could be, I don't know. I know at least a couple. I know one in the Senate was fairly political that changed, but then the other one flipped, so it offset it.
Okay. Question over here? I'm sorry, right here in the middle? Okay. Go ahead. I'm sorry, who had their hand up here?
I think he's, yeah, there you go.
Oh, Robert, okay, Robert, beg your pardon.
Governor, has the state legislature...
Robert, just identify yourself.
Oh, Robert Pear, New York Times. Has the state legislature passed legislation authorizing creation of a state-based insurance exchange? And do you think Arkansas will have a state-based exchange by 2016?
Yeah. Well, that's a great question. Yeah, they're headed now in the direction of a state-based exchange. I tried to get them to do that to begin with when all this stuff first came out, and they didn't want to do it. The legislature did not want to do it. I guess I could tell this story, Matt.
Sure you can. Sure.
I mean, after all, this is just between us, right?
You got it.
Last year we were riding over to the White House on Monday morning, as we'll do here in a minute, as we always do, to have a couple-hour really intense session with the president, whoever the president is. And Butch Otter was, I sat down on a little minibus that we go over in, and Butch Otter, the Republican governor of Idaho, was with me. We came in together 8 years ago. Nice fella, philosophically, there's some differences between us, yeah. Former member of Congress. And he said, what are y'all doing on the exchange? Y'all doing a state exchange? And I said, no, we did a federal exchange, but we actually did the hybrid partnership kind of thing. I tried to get, oh, you can't do that, he said. You got to do a state exchange. If you do a federal, Obama just wants, hey, he wants everybody to do a federal exchange. That's how they're going to take it all over. I said, you need to come to Arkansas and tell them what I've been telling them about wanting to do a state exchange. So the irony of all this is the very Republican, anti-Washington healthcare contingent, when all this came out, that didn't want a state exchange, now has come to the conclusion that they want to reverse their position and do a state exchange. So yeah, we're headed in that direction, to answer your question.
Okay. Over here.
John Reichard with CQ Roll Call. If the vote doesn't go your way on Tuesday, what other opportunities do you see for a vote? When do you think we'll see
Yeah, they'll vote again
additional
Wednesday.
votes? What's
They'll
that?
vote again Wednesday,
Wednesday.
and then they'll vote again Thursday.
Okay.
But doesn't every time you have a vote, doesn't that open the door for a lawmaker to say, you know, to keep my vote, you need to do X?
Well, you about run out of X's. You know, I mean, it's you can't, you just can't go. First of all, it's not fair to the 73 or 71 or 68 or 52 that have always been there. It's not fair to start making deals with somebody at the 11th hour unless it is something that benefits the entire state, that's not specific to a specific legislator. Because if you start that stuff, then the folks that have always been with you that didn't ask for anything and were just trying to do what they thought was good public policy will, you'll lose some of that support. So, I mean, that's a fine line to walk. You can't just start trading stuff away. Besides, we don't have anything to trade.
Okay. All right. In the back right there.
From Bloomberg Radio. Governor, what are the insurance companies who stand to lose if you lose? What are they doing to help you? How about other companies in the state, like Walmart, Tyson, which have low-wage workers who qualify for
Yeah,
Medicaid?
they're doing
What are they doing to help you? And could I ask one other thing?
Sure.
Medicare Advantage costs the government more money than straight-out Medicare. How did your insurers manage to cost you less money than straight-out Medicaid?
Well, let me go back and take the first part of that question. The private sector is doing a lot, and it depends on who in the private sector's ox is getting gored the most as to who's doing more. For example, all the hospitals are working there, and the board members in the private sector that support hospitals, and the local chambers of commerce, and the folks that acknowledge and recognize the ramifications of not continuing this for their individual hospitals, particularly some rural hospitals, are working very hard. The Chamber of Commerce statewide is working very hard. I mean, they get the arithmetic too. I mean, what we're seeing is what I call the traditional Republican business community is aligned with the Democrats. How y'all like that? And that's how you got a 3/4. And so traditional Republican business interests are totally supportive of continuation of the private option. Now, when you're talking about Medicare Advantage, you're talking about something else I'm not even messing with, so I'll have to ask somebody else about that. I can tell you that part of what we did with regard to the waiver was to keep the costs pursuant to the insurance rates for Medicaid expansion, in our case with the private option, had to be within the parameters of what was anticipated by expenditures by the federal government. And that's where we are. We've been able to do that. And we've been able to do that to some extent with some additional competition.
Okay. On this side of the room, would it be fair to everybody? I'm sorry, I can't. Go ahead. Right ahead.
Carl Stark for the Philadelphia Inquirer. So in Pennsylvania, we have a governor who's trying to out Beebe you, sir. He's trying to do require a work search. He's trying to do changes to all the existing Medicaid recipients.
Well, we haven't done all that.
Pardon me?
We haven't done all that in the private option.
Right. And
We haven't required the work stuff, and we haven't changed the existing Medicaid requirements.
Right. And so what do you think the prospects for success are, like in Pennsylvania?
You'll have to ask. You're a better judge of that than I. I love Philadelphia. I'm mad at you. You closed Lebec Finn, which was one of my favorite restaurants in all of North America.
We could send you takeout.
You know, you know, I can't answer that question. I think Corbett has, as a lot of other governors have just looked at the pure math. Their people are going to pay for this, whether they take it or not. Their taxpayers, their hospitals are going to pay for this, whether they take it or not. They are not going to impact the federal deficit or change what's going on with our national debt, whether they take it or not. And a lot of them have awakened to that. I mean, I hate to be repetitive and give Clinton too much credit, but it is arithmetic. Really, people. And the logic of it permeates most of these people. Now, I'm not calling out names, so you'll have to judge who it doesn't permeate yet. I mean, I don't know any look, most of our people in the legislature do not want and do not like Obamacare, as they call it. This is not an endorsement of Obamacare in Arkansas. If you took a vote in Arkansas, it'd be 68–70% of the folks would be opposed to the Federal Health Care Act. And if you took a vote in the legislature as to how they'd vote up or down as to whether this continues nationally, they'd vote against it. They have been able to separate the fact that they can't control in Little Rock, or you're not going to control in Harrisburg, what they do in Congress. It is if you don't like it, go to Congress, vote. Run for Congress, win. In the meantime, you have an obligation to your people in your own state to do what's best for the people in your state with the cards that are dealt you. And so these cards have been dealt the entire country. And the entire country is dealing with it in different ways, but most of these governors now have recognized that there are major advantages to their state and to their people to take it if they're paying for it anyway. And so that's what the fight is right now. How do you get there? And a lot of them are constrained by the pure politics of their own situation. And, you know, my argument is, I mean, we're all supposed to do what our people want. I mean, we're representatives, okay? I get all that. But a governor has a responsibility to lead, too, and to educate, too. And sometimes, it seems to me, it's easy for me to say I'm not running for anything else, okay? But I would like to think I've been this way all my life. And part of my responsibility, and I think part of anybody's responsibility, is to help educate your own people about what you believe is appropriate, good public policy. And I think a lot of them are now starting to do that and trying to do that, including a lot of Republican governors. A lot of Republican governors who, did anybody see Jan Brewer pointing her finger in Obama's chest a number of months ago? Huh? Anybody think she's a big fan of the president or what's going on? She took it, and then she said if they don't keep it, it wrecks her budget. It's arithmetic.
So you think it's just a matter of time before the governors that haven't accepted the Medicaid expansion do so?
No, there's some I don't think it'll ever do it, and I'm not going to go there. But I think more and more are trying to find a way to do it. You all have reported on some of it. You've asked questions about specific names on some of it. I certainly have been asked by many of them about ways to do it. So yeah, I think it's incremental that there'll be more and more.
Okay.
Now, I know this is what y'all want to talk about, but let me just throw something else out at you that's related to all this because I think it's important. Maybe a bigger deal than what you're talking about in the long run, if y'all are healthcare reporters. And maybe something that I've been asked about by members, by other governors as much or more than Medicaid expansion / private option in our case, and that is payment reform. We are actually leading the country in a methodical, logical, and reasonable way to reform the way we pay for health care in this country. And I think that's going to be ultimately the huge story before it's all said and done. And we got to get away from fee for service, and we're doing that. But I don't make public policy in Arkansas in a back room with a bunch of staff members. I think you involve the actual frontline people that have to implement whatever that policy is as you're formulating the policy, not after you've done it and said, here it is. And so we've had the medical community, the hospital community, other providers, the insurance community, patient advocates, and all sorts of folks from the beginning over a couple-year timeline and incrementally and slowly shift away with various episodes of care away from the old fee-for-service model into something that, and this is hard to do, it's a balance. How do you reward quality? How do you ensure quality and efficiency, cut costs? You would think that would be mutually exclusive. It's not. Let me give you one quick anecdotal story that I keep telling over and over about this because I love it. One of the first episodes, and the way this works, and I've got Surgeon General here and I've got our Medicaid Director here if y'all got real questions that I can't answer, is you've got a baseline of, say, what it's normally going to cost for a certain procedure. Now, there's got to be a safety net for unforeseen consequences, et cetera. But one of them was pregnancy and labor and a normal delivery. And here's the baseline. When we were establishing all this stuff, we had a really fine OBGYN in the Little Rock area who just raised Cain. You can't do that. All of my costs, all of my deliveries are way over this line. I'll lose money on every delivery. Can't do that. Well, unbeknownst to him, and with a little bit of self-examination as all this was occurring, in every pregnancy, in every delivery, his office was sending every placenta to the pathologist, whether it was called for or not, whether there was any reason to be doing that or not. And so, I mean, the pathologist was making a little money on it, but he didn't know that. The office was doing it as a matter of routine. When they stopped that and decided to send only placentas that required to be sent for pathological examination, his baseline dropped below. He's going to make more money. And what's going to happen? The taxpayers, the insurance companies, everybody in general are going to be paying less. So, I mean, that's where this country's got to go. And everything we talk about, we had Ben Bernanke there yesterday for a governor's only thing. And people kept talking about, the GDP and where the country's going and what the economy is going to be like. And consistently, healthcare costs, both public and private healthcare costs, continue to be the unknown factor including with the entitlement programs, that pose the greatest threat to the stability of the economy going forward. And if everybody's going to talk about our health care costs being unpredictably bad, and if everybody's going to talk about the fact that we don't have any better outcomes than a lot of other Western industrialized nations that are doing it differently, then we better do something different. And we've started it in Arkansas, and more folks are starting to do that. I'm sorry that wasn't what you all wanted to talk about, but you need that in your radar because that's the next big story, and ultimately maybe the bigger story overall.
Okay, I saw 2 hands up here.
See, I wasn't making an open
Let me
statement.
start back there, and then we'll get you next time.
I'm Jeffrey Hess with Mississippi Public Broadcasting.
Oh, boy.
You've addressed a lot of the questions I was hoping you would, but I'm just curious. I've heard Democrats in my state make all the same arguments you're making, and they've fallen basically on deaf ears.
Yeah.
If you think the branding of the Arkansas plan versus it being Obamacare will make it any easier to bring Republicans to the table.
Somebody asked me that question the other day, said, did you do this just because you changed the name of it? That's more than that. It's what we did was substantive as well. And I give a lot of our Republicans credit, what I call traditional business Republicans, because they helped formulate this, and they deserve a lot of credit. This was truly a bipartisan approach. Yeah, it had a different name, and did that have an effect on some folks? You bet. But it's more than that. It was honest to goodness, substantive differences that lent themselves to private sector support. And it certainly provided a pathway for folks in our state, even with a 75% requirement. If I were talking strategy, I would talk about that in Mississippi or Alabama or in South Carolina. I think that there are principles that we utilize that would be appealing to some folks on the other side of the aisle. And I think Democrats embraced it pretty wholeheartedly. At least our Democrats did. And so if you're asking me, would approach like this help in your state? I think it would. I think the starting point, though, you got to get a bell cow, whether it's a legislative leader or a governor or whoever, that has to embrace it first, and then start trying to sell it. That answer your question? Mostly. What else? What else do you want?
I mean, the Democrats in my state pitched your plan, and it didn't go anywhere. So, I mean, it seems to me it's not quite the answer that people in my state are looking for.
Well, you're probably right.
All right, right here. Who's got the mic there?
20 what? Seconds?
Sorry, I can't see. Okay, whoever has the mic, go ahead.
Hi, Governor. Martha Beebinger. I work for Public Radio in Boston. Thanks for your time.
How are you?
Doing great.
I'm mad at the Red Sox. They beat my Tigers.
You know, you'll have next year.
Okay.
You'll come back. So my question is, who, meaning government or someone in the private sector, makes sure that savings, if there are any, in payment reform, come back to me, the consumer?
That's a really, really good question. Theoretically, competition will generate some degree of those savings. If indeed healthcare costs are going down, then theoretically health insurance company A is going to have to lower some degree of rates to be competitive with health insurance company B. What we also have is the ability to take the data and present the data, in our case, to our insurance commissioner, and transparently let the world know what the data is actually showing. I frankly don't think this is going to cause a lot of reductions in what we're spending. I think what it's going to do is stop the growth, which is just about as important. The upward spiral of healthcare costs outpacing inflation is, and outpacing growth in general, has been the huge problem in terms of eating into our GDP. So I wouldn't be overly optimistic that all of a sudden when we do all this and implement all these episodes that we're going to see significant reductions. I hope we see some. We've seen a huge leveling off, but the whole country has with regard to healthcare costs. Our Medicaid projections are much better than they were a year and a half, 2 years ago, but so are everybody else's for that matter. So we've seen some stagnation in that inflationary spiral. Do you all have any thoughts on any specific ways that the savings are going to actually show up and be realized in somebody's pocket in terms of their health care costs?
Let's get you a microphone before you answer.
Got to give him a mic.
He needs a microphone.
I just asked him to talk.
Yeah, if he could do it.
He's the Surgeon General of Arkansas.
Just introduce yourself.
Sorry,
And
Joe
he doesn't know
Thompson.
squat about insurance, so he's not going to be able to help you with this question.
Joe Thompson, Surgeon General for the Governor. I think two parts. One is increased competition. Our marketplace has not been very competitive, so with payment improvement combined with expanded coverage, we will hopefully have increased competition. The second is the savings actually are equally dispersed between, as the Governor said, the payors and the providers. So the payors, in turn, will transmit those savings back to their customers, whether the customer is a business paying for insurance or an individual buying insurance.
And I don't mind you being skeptical about this, and I think it's worth watching very, very closely to ensure that it works. But I can tell you what we're doing is not working. Where you reward through payments every test, that's not conducive to efficiency. And it doesn't necessarily help for quality of care. And you know what, with the technology we've got now, if somebody does an MRI in Hospital X in a rural area, they can immediately transmit now, and the doctor in Hospital Y in a metropolitan area can in real time have that information and doesn't have to do another MRI 7 hours, 10 hours, 12 hours later, unless it's called for because of some particular thing that's going on with that patient that's different. And so in the past, you get paid for the extra MRI, whether you needed it or not. Now you're not going to, not unless there's a justified reason for it. And that's the way across the board with tests and everything else. It also rewards and puts almost in a patient-centered medical home the burden and the responsibility and the coordinated care effort on the part of the primary care physician. Puts that primary care physician in control. And you know, we've got so much in the way of health care costs, and I don't mean to get off into this because it's different what you're talking about, but you ask a good question. That a lot of this stuff is manageable to keep health care costs down. You know, a lot of these conditions, whether it's diabetes or high blood pressure or whatever it may be, properly managed with a proper primary care physician, making sure people do what they're supposed to do and have a reward for being able to follow up on it, can prevent a lot of higher health care costs down the road in a more expensive setting.
Okay, I think we had a question right back here.
Hi, Diane Weber with Kaiser Health News.
Hi.
I wanted to go back to something you said earlier about small business. You said you have something like $38 million savings for the private option. Is that because people who are working for small businesses would be eligible for that private option, so the small business wouldn't have to?
Yes. Yeah, that's the estimate. And again, part of that's been delayed. They keep delaying the implementation of the penalties. But that is an estimate that was done based upon those folks that fit those categories. And you know, I mean, we got a lot of small businesses, convenience stores, and folks that might, in the aggregate, because of the way it's imposed in the number of stores, be over a 50-employee threshold or be in a threshold where they would otherwise have to pay a penalty, but they're not paying the kind of wages that would allow them to have subsidized health care, and they'd fall within that 138% of poverty level. And that's an estimate of what penalties would be, would not have to be paid by an amalgamation of those businesses across the state. Is 38 right? Nobody knows for sure, but that's as good an estimate as our folks could come up with. And it weren't our folks, this was private sector estimates. I saw in one, I don't remember whose publication it was, might have been Politico, but I saw recently an estimate of something like $300 to $400 million a year is the hit on Texas small business. Did anybody see that? Am I the only one that saw that? Matt, you saw it. Where'd Matt go? You saw it. Yeah. Y'all didn't see that? I thought y'all were in the news business.
We're going to look it up as soon as it's over. How about this side? Anybody?
Could I just ask another
Oh,
question?
Diane, sure,
unrelated?
follow up.
How long have you had that 75%?
Long
held to
before I
get
was
over?
born. Long before. Back in the 20s or 30s, I think.
Really? Wow.
Yeah. Yeah. Trust me, it's not my idea.
All right, we have one right here.
Jane Tribble with Ohio's WCPN Public Radio.
Uh-huh.
In Ohio, we've had quite the contentious battle over Medicaid expansion as well.
Sure.
One of the questions I'd like to ask, and it follows up on Martha's question, is cost analysis. You talked about 100,000 people being on there. How are you guys accounting for cost savings at this point? You mentioned several ways that costs are being saved. So how do you tally that up, and how do you report it to the public?
You're talking about the 80-some odd million dollars I mentioned that we saved as a result of it.
So how are you showing that?
You know, that's a great question, and I'm not doing a very good job of explaining that on the front end, because really we had people running for governor right now in Arkansas that asked that same question, which shows I wasn't doing a very good job of explaining on the front end. That money's already been saved. We were it's primarily in two areas. We were giving state general revenue to various providers, including but not limited to the Med Center and other folks, community health centers, et cetera. We were paying X amount of tax dollars in our annual budget in the form of general revenue to offset uncompensated care. So we didn't take all that back because they're still going to have some uncompensated care. The various entities are still going to be treating folks for whatever reason that don't pay a dime. And so we didn't do 100% pullback on all the uncompensated care dollars that we were spending out of our budget to various entities, but we did a significant portion. Then there's a small but important portion of existing Medicaid people. Breast and cervical, tuberculosis, et cetera. There's a certain population in everybody's existing Medicaid program that can legitimately go over to Medicaid expansion, right? So they go from us paying 30% to us paying 0 on a state share. And you know, that varies from state to state. You understand what I'm saying there? So a combination of those things saved $89 million that we were spending in our regular budget already before any of this stuff came up. Now we don't have to spend that. So that savings was automatically created because those obligations were relieved by the private option. So it's not a question of how are we going to track the data, how many are signing up. We already know that data. It was in the budget. You follow what I'm saying? Now, if we don't do the private option, then that $89 million theoretically would be paid somewhere, right? But we already gave it back to the taxpayers. Because we cut taxes, we cut our overall income in our overall tax policy by an amount of money equal to what we were saving in not having to spend that money in the uncompensated care or in the traditional Medicaid, the folks that could legally and legitimately move over to Medicaid expansion. That's the problem. And I've not done a very good job on the front end of explaining that because that's a great question. You asked a great question, and others have asked that question. I've got to do a better job of explaining how that $89 million savings exists, because it's not a savings based like on saving penalties from employers. It's an actual savings that's already been realized and quantified in a budget. That makes sense? Okay.
For our last few minutes, do we have, I've been curious about what happens to the prices in your exchange plans if you didn't get additional money for the private option, because the overwhelming majority
Yeah.
of people in the exchange are the private option.
Yeah.
If that money goes away, it's not continued, what happens to your risk pool
Yeah.
in your exchanges? What happens to those premiums next year? How will that play out?
It'll have a devastating effect, it seems to me. I mean, everybody knows, perhaps because of the rollout, who knows, or problems with the federal rollout, et cetera. The subsidized portion of the population is, as you mentioned, significantly less at this point than the Medicaid expansion portion of the population. And you pull that whole pool out, then the insurance companies and the pool that's paying for all this theoretically has an upward cost spiral on it. And you may lose some of the insurance companies that are otherwise there. And certainly the ones that are left, undoubtedly you may have increased insurance premiums as a result of that. I mean, it all needs to work together, and that's a great point, that it'll have a negative effect on the subsidized pool.
Sure. Right. All right, folks. More questions? Yes, go ahead. Well, wait a second, Phil. Let's get you a mic. Hold on. So everybody can hear you.
So you're leaving here and going down the street to the White House. What are you going to talk to the president about? What health issues?
Probably not a lot of this. I mean, again, you're going to sit there with a bunch of Republican governors and a bunch of Democratic governors. We're going to be talking about it to the president. To the extent that we do talk to the president about health care issues, one of the things is a question I think you talked about early on. I think we'll be talking about the ease and the streamlining, if you will, of the waiver process. I think there's pretty much unanimous agreement on that aspect. But we'll be talking about other stuff. I tell you, one of the things that hasn't got anything to do with what you're talking about, that all 50 governors are really fired up about right now, is the National Guard cuts. I mean, those are the kinds of issues where you're going to see so much unanimity on the part of the governors. That'll probably be the bulk of what's talked about. No, I don't think you're going to change anybody's mind in the course of a 3-hour meeting with the president on where they stand on health care right now.
All right. So I think we'll leave it there. I want to thank you so much,
You
Governor
bet.
Beebe, for being
Good
with
to
us.
see
Really
you.
appreciate it.
Absolutely.
Good to see you. I want to thank
Absolutely.
Health Affairs, and I'd like to thank everyone for coming to participate this morning, and we hope to see you back here for future events. Thanks so much.
Bye-bye.
Thank you.